All right, so this presentation will be focused on viral therapies for glioblastoma, and it will dovetail with many of the immunologic therapies that are being utilized in brain tumors. And although the presentation is focused on glioblastoma because this is where it's been most extensively studied, a lot of the lessons could be applied to other tumor types in the future. Here are my disclosures. The one that's probably relevant to the presentation is I have received research support, immunotherapeutic drugs for clinical trials from BMS. All right, so the learning objectives here. So we want to understand how viruses can be used to treat cancer in the brain. We want to understand what the limitations are for viruses that they need to be able to overcome to be successful in this. I'm going to review a few specific examples of viruses that have been studied and are being studied in glioblastoma. We'll go over 4 specific clinically relevant examples. We'll also delve into how viruses can be used for gene therapy, and there'll be sort of 2 components to this, the oncolytic aspect or cancer killing aspect, and then the gene therapy aspect. And we'll talk about what makes each of these approaches unique. And then we'll understand what questions viral clinical trials are attempting to answer and how this information can be used to interpret the results. And we'll give a few specific examples. My hope is for this to be interactive, and I think that we should finish the didactic portion early enough to be able to discuss any of the questions that relate to viral therapy or immunotherapy more broadly in neuro-oncology. All right, so we'll go over a little bit of background. We'll cover viral therapy, dividing it into 2 big categories, oncolytic or cancer-killing viruses, and then viral vectors, which is just a conduit for bringing something from one place to another. In this case, bringing something, gene of interest into a tumor, and then we'll conclude. All right, so why are viral approaches attractive in GBM? So there are GBM specific factors, and then there's sort of the general factors in all of oncology, where we have our proof of principle that this type of a concept can have value. And the best example of this is going to be efficacy in other cancers, and specifically within the context of melanoma. FDA approved in 2015 an HSV or herpes simplex virus in LIGIC for the treatment of melanoma. And this has become part of the standard of care. What's interesting is that it hasn't been probably used as widely as some may have anticipated, because there are other newer therapies that have come along that have demonstrated even greater efficacy. Now, that being said, viral approaches by themselves have some element of efficacy, but we suspect that there can be synergy when we combine it with other treatment modalities, meaning combining a virus with something else has the potential to make things even better. Now, the question is what that best thing to combine it with. Is it another immunotherapeutic approach? Is it a traditional cytotoxic chemotherapy? Is it radiation, et cetera? And we're going to delve into some of those examples as we move through our presentation. So now, why would we want to study viruses within the context of glioblastoma? So 1, the standard of care is not curative. So what we do right now, even though it's of the greatest benefit for the largest number of people, is still not good enough. And so we need to constantly keep improving. And this is one very promising avenue of investigation. Number 2, the tumors that we deal with in neuro-oncology oftentimes have a lot of what's called tumor heterogeneity. And that means that the tumor is really complex. And so this part of the tumor over here is different than this part of the tumor over here, and different from this part of the tumor over here. And this is notable at the what's called histologic level, meaning when the neuropathologist looks at it under the microscope, they can see that there are differences between different parts of the tumor. And then it's also, even more importantly, different at the molecular level. So there are some abnormalities within the, say, glioblastoma that are present in one part of the tumor but not present in another. So, for example, if we use a targeted therapy and it goes after a specific target, and that target's only present in 10% of the tumor cells, we may be very successful in killing off that 10%, but now we still have that 90% that we have to address. What's exciting about oncolytic viral therapies is that they're not based typically on one very specific target. It's based more broadly on the tumor and tumor cells as a target overall. So it has the potential to overcome that tumor heterogeneity that some of our other modalities are not able to overcome. Another GBM specific factor for which viruses are potentially attractive is the disconnected infiltrating nature of glioblastoma. And so the example that I think about is breast cancer. So in breast cancer, we have a tumor that's growing. That tumor begins to infiltrate, to get into some of that surrounding tissue, but it does so to a small degree. But the real problem arises in breast cancer is once that tumor can figure out how to get out of that main tumor into the blood vessel and then travel to other parts of the body. Now we can juxtapose that to glioblastoma. And so glioblastoma, we don't have to worry about it going to other parts of the body, but glioblastoma is interwoven with the good brain. And it's interwoven with the good brain in a disconnected infiltrating fashion, meaning that as neuro-oncologists, we sometimes make the mistake of saying it's, fingers or tentacles that are going through, but it's not fingers or tentacles. One of my colleagues who is also at the ABTA conference, Craig Verbinski, describes it as ants. And so it's not, one octopus with all the tentacles sticking out. It's a bunch of ants that are crawling through and causing the problem. And what's attractive about viruses is viruses have the potential in certain circumstances to be able to spread further afield and not have to be contiguous and go from point A to point B and try to chase after some of these last remaining tumor cells. So those are sort of the big overarching concepts on why we would be interested in this type of an approach. So what are the hurdles that we have to overcome for this to be successful, right? So not everything is easy as it seems. So there are a number of things with any therapeutic that we have to overcome. With viruses specifically, there are a few things that we want to consider. Number one, our bodies are made to get rid of viruses, right? Whether it's the cold virus or the COVID virus, et cetera, they're designed to be able to clean this stuff up. And in particular, we want to be able to clean this kind of stuff up from the brain, right? We don't want to have viral infection in the brain. And so our immune systems can get rid of the virus. And if we're using the virus as the therapeutic, we have the potential to have our bodies clean it up way too fast before it can cause the damage to the tumor, which we want it to do. In addition, viruses may have difficulty traveling from the site of delivery, meaning that if we put them in one place, they may or may not be good at getting to other places. There are plenty of specific examples where it's been demonstrated that they can get from one place to another very nicely, and other examples where it's been demonstrated that, hey, they didn't really go too much further than where they were injected. Okay, so that's something for us to think about. What is the distribution of our therapeutic? Number three, viral dosing may be difficult to optimize. So this is not like taking a drug and saying we're going to give you 50 milligrams and then we're going to give the next group 100 milligrams and the next group 200 milligrams, et cetera. And all that's already been evaluated in animal models, meaning mice with these brain tumors. And we figured out what we think the optimal dose is in the mouse. And now we're looking at it in people, and we can measure how much of the drug is present by checking your blood every so often in our early phase studies. We can't do the same kind of thing with viruses because the viruses are typically injected intracranially, meaning into the tumor itself. And so it's not practical for us to be able to sample what's going on within the context of the brain, in real time. In addition, when we look at preclinical models, meaning the mice and other animals being treated with these viruses, it really does make a difference how much virus is given. So if you don't give enough, it doesn't do anything. If you give too much, the toxicity is too great. And so viral dosing is something that has to be optimized. Number four, robust response can cause substantial brain swelling. So one of the things that we want the viruses to do is to lead to the death of a lot of tumor cells. And if we kill off a lot of cancer cells all at once, then that in turn causes a swelling. And that swelling has the potential to be profound. And that was one of the biggest worries, particularly early on in that viral therapy era when we were first looking at these. Number five, glioblastoma is defined as what's called an immunologically cold tumor. And that means that the immune system within the glioblastoma and the surrounding brain has been dampened down. And so in turn, the immune system is not able to be as aggressive as it wants to be. And so, sorry about that. And so because of that, we're not able to as easily attract all the immune cells that we would want to when we kill off the tumors. And even when those immune cells get to where they need to get to, they may be turned off by the tumor itself. So the immune cells that should have done a nice job killing off cancer are turned off. Number 5 or 6 or whatever number we're on, tumor mutational burden is moderate and heterogeneous. So we talked about heterogeneity, meaning not everything is the same in the tumor at the molecular level. And one of the things that we're interested in is how many mutations are present. And one of the problems that we can see is some part of the tumor may have lots of mutations, some part may have very few mutations. And for the immune system, when something has a lot of mutations, it's read as abnormal, and then the immune system may want to go in there and kill that part off. But the problem arises if that's not present throughout. Number 6, many GBM therapies can impede immune activity. So our radiation decreases the immune activity. Our chemotherapy decreases the immune activity. Steroids, which patients may receive for swelling, decrease the immune activity. So we have to keep all these things in mind when we're thinking about the timing of the viral therapies for glioblastoma. And then the last point is that our preclinical models may not always reflect the conditions in adult humans with GBM. And that means that before we try and investigate something within the context of patients, we want to know whether this makes good sense. And one of the ways that we do that is by preclinical modeling. And so we work closely with our colleagues in the laboratory who treat tumor cells in a petri dish, who treat mice with these brain tumors, and see whether this is a good concept or not. Now, an example of how that preclinical modeling doesn't always match up with what we're trying to deal with is age-related modeling. And so a lot of times the animals that are being tested are mice that are young, and they don't reflect the adults who have glioblastoma. So the typical mouse model is equivalent to 11 to 16-year-old, versus the most common age of a glioblastoma diagnosis is around 65. And so in turn, what we're looking at may not, in the laboratory, may not always reflect what the patient population that we're trying to treat. So we have to keep all those factors in mind. So now we're going to delve specifically into oncolytic viral therapy for glioblastoma. And one of the concepts that I want to highlight is, in the contemporary era, we're not just thinking that oncolytic or cancer-killing viruses just kill the cancer. We also think that as those viruses in box A kill the cancer, they release a number of other factors into the surrounding microenvironment. And our immune cells, these purple cells here, come in and they pick up some of those factors and say, aha, this is very abnormal. This is attractive to me. And then they carry that information to the lymph nodes and they teach other immune cells how to do what needs to be done to get rid of this. And then ideally, this all leads to these orange immune cells coming into the tumor itself and starting to kill off the other remaining tumor cells in that area. So we think it's a two-pronged approach, that you have something that goes in and kills off a lot of cancer, and then in turn stimulates that immune system to get it to work a little bit more aggressively. And this is from a review by Katie Peters from the Duke group. So now oncolytic viruses, we have a number of different viruses that are investigated. Examples are HSV, which is the herpes virus, adenovirus, so common cold, measles, polio, Zika, et cetera, et cetera. As a non-basic scientist, as a clinician, from my perspective, if there will be success in viral therapies, it is likely that it will end up being what's called a class effect, meaning that a bunch of different viruses will be effective. And then we'll sort of fine tune which one's a little bit better than the other. What kind of things can we do to improve upon it? But it's kind of like saying, one brand of automobile versus another brand of automobile. With a Ford and a Chevy and a Toyota will all bring you from point A to point B. And you can argue the nuances of why you like one car more than the other, and one car may be better than others for doing certain types of things. So that's the potential lay of the land as things progress. As I said before, the viruses are thought to be oncolytic or cancer killing as well as immune stimulatory. Some advantages about these viruses are they can potentially kill a wide range of tumors. And so earlier we talked about how we have these different subpopulations within the tumors themselves. And now we have a virus that can be engineered to get rid of all these different types. In addition, they could potentially kill tumor cells that are further afield. So we talked about that non-contiguous spread of the tumor, where you have something here, something here, something here. Ideally, that virus can be made to chase after all those. In addition, these viruses, when they're stimulating the immune system, they're probably stimulating both the innate and adaptive immune system. And that's a concept that's, I think, important for us when we're thinking about immunotherapies. So we have our innate immune system. These are our frontline soldiers that are going in there to kill off whatever is there. And they're doing it in a relatively indiscriminate fashion, which is nice because they can kill a wide range of different things. And then we have our adaptive immune system. So it adapts to say, hey, I can do an even better job of killing. It's going to take me a little bit of time to learn. It's going to take me a bit of training, but these are the special forces who can go in and then kill certain types of tumor cells to a greater degree. And again, oncolytic viruses can take advantage of both of these aspects of the immune system, which is exciting. So here we have a really busy slide that lists all the different clinical trials. This is from 2021 at that time point that were active or had completed accrual for using oncolytic viruses in glioblastoma. And so you can see there's this gargantuan laundry list. So a lot of people who are very interested in this area, a lot of activity going on, all in various stages of development. There's a wide range of viruses that are being utilized, a number of types of study designs. And so we're going to talk about a few different specific clinical trials using specific types of agents, just as examples. Now, there are plenty more, but these will just sort of serve to highlight a few key points. The first one I wanted to bring up was Delatac, and this is a oncolytic virus. Oh, sorry. The first one that has been the first one that's been approved by a regulatory agency for the treatment of glioblastoma, and it was approved in June of 2021 in Japan. It is not approved by the FDA, but it has received regulatory approval elsewhere. And it received regulatory approval based upon a really small study. So what's called a non-randomized phase 2 study. And so the phase 2, meaning it's looking for a signal of efficacy, meaning does this work? Non-randomized, meaning everybody got the same thing. So it didn't compare one group to the other. And it's small in size, and the N means how many patients were treated. So just 19 patients. Okay, and if we juxtapose that to the trials that led to the FDA approval of Temodar or Tumor Treating Fields, we're talking more in the 500 to 700 range. So this just gives you an idea about how much smaller that scope was. In addition, it treated patients with a range of sort of disease states, from the newly diagnosed setting to the recurrent glioblastoma setting. We know that those are not exactly analogous. The outcomes that they were able to demonstrate was, number one, overall survival 12, or OS 12, the percentage of patients alive at 12 months, and that was 84%. And then the progression-free survival, which is the PFS, was relatively short at 4.7 months. And so there's this discordance between how the scans look and how patients look. And so one of the points that I wanted to highlight here is that when we're using novel therapies, it's going to take us collectively in the neuro-oncology community some time to get an understanding of how these therapies affect our scans. And it may be that something can improve survival, have people live longer, but the scans don't look so much better, or they don't look better for much of a time period. And that's a theme that you're going to kind of see over and over again when we're talking about the next viral therapies. So the next one I want to move to is probably one that's the most renowned, and this is from the New England Journal paper by Bionic Desjardins that came out in 2018. This is using the polio rhinovirus chimera. So this is a combination of two different viruses to treat recurrent glioblastoma, meaning glioblastoma that is grown. These are the results of the phase 1 study. It was a dose escalation study. So what happens in these early phase studies is patients start out with that low dose and get more and more. And you recall at the beginning, I said, it's difficult to figure out what the optimal dose is for oncolytic viruses. And it's probably also really important to figure out what that dose is. And one of the points I want to highlight here is that the dose that they felt was the best was dose level minus below their starting dose. So as they go up, it's too toxic. And then they go back down again to less than what they had began the trial with, to less than what they had assumed would be a reasonable starting dose, and found that that was the best. And the reason I want to highlight this is, as patients, as family members of patients, there's this sort of intrinsic desire to not be on that first dose. There's this desire, if you're in an early phase study, there's this desire to get the highest dose of drug. And sometimes the highest dose is not the best dose, okay? Now, the overall survival at 24 months here was 21%. So it may have been effective in some patients, but not all. And then over to the right, I have one of the figures from that manuscript, and this is showing the treatment effects. And so it speaks to the idea that there can be a discordance between improved survival and how the scans look. And the first column that we have there is with treatment with the oncolytic virus. And what you can see is that as you move from A to B to C, things look worse pretty fast, right? Yet, when that same patient subsequently got CCNU chemotherapy, the unexciting alkylating chemotherapy that we use all the time and it's been around for half a century, we see that those patients really had things shrink down remarkably. And so one of the concepts that this brings up is, does a treatment with an oncolytic virus or other immunotherapy kind of prime the tumor to be particularly susceptible to some of our more traditional chemotherapies? Does it kind of, install some sort of Achilles heel or some sort of other weakness within the tumor where it can't handle our, standard chemotherapies anymore? And that's a theme that we can see not just with oncolytic viruses, but it's a theme that we have seen in some other immunotherapeutic trials. The best example that I can think of is the ribopepimut study. It also begins to beg the question of maybe combining these therapies with agents like CCNU at the same time may be reasonable. That's one of the things that the team developing this has been studying. Okay, and now we're going to do one more final oncolytic virus before moving into viral vectors. And this one has a very sort of awkward name, NSC-CRADS-PK7. And that's, I guess, another theme that we can see carried throughout is that we'll have all these sort of sets of numbers and letters to delineate what a virus is. And this is actually from our group at Northwestern. And this is using oncolytic virus, adenovirus, to try to overcome some of the weaknesses within the context of viral therapies. And what it does is it takes that virus and then buries it inside of a neural stem cell. And we think that that's advantageous for two primary reasons. And so one of those reasons is the immune system is set up to not get rid of neural stem cells. And so we said one of the problems early on is that your immune system can clean out all your therapeutic virus. And so here you're trying to protect that virus from your own immune system so it can do its job, it can kill cancer. The other thing that neural stem cells do is they travel to areas of injury. So if you have a stroke, you'll have neural stem cells go over there and try to fix everything, rewire the system. If you have a tumor, neural stem cells will traffic to that area of interest. And so here's a way to potentially get these viral particles as far, to the furthest away tumors as possible. So this was a phase 1 dose escalation study, small number of patients, and it combined this treatment with radiation plus Temodar chemotherapy, plus more Temodar and possibly tumor treating fields or Optune. And the overall survival and progression-free survival looked favorable. Here we have some images at the bottom showing nice stability of disease over time. With all these studies that we're presenting, we always want to be cautious with regards to how we're interpreting the data. Patients in early phase studies are very selected. They're not representative always of the general population. Patients in surgical clinical trials have to meet a number of different inclusion and exclusion criteria to be able to qualify for that. And so again, there are questions with regards to how easily is this generalizable. Okay, so now we're going to shift from the oncolytic viruses to the viral vector therapy for GBM. And so here is a specific example that we're going to be talking about. So oncolytic viruses, again, kill a bunch of cancer cells. Viral vectors bring something to another place. And in this case, this is an example of a set of viral vector gene therapies. And so what happens is the surgeon cuts out some tumor, injects via freehand injections into the surrounding tumor tissue this virus. And now this virus goes and tries to infect the tumor cells and then bring a gene into those tumor cells. And then the gene is something that we can turn on with a pill. And the gene then leads to the tumor expressing something called IL-12, which is a pro-inflammatory cytokine. So it's like an on switch for getting the immune system to be riled up in that area. And if we think back to the beginning of this presentation, we had discussed how the tumors are oftentimes immunologically cold. They're designed to sort of, keep the immune system dampened down quite a bit. This tries to overcome that. And something that we can manipulate, we can turn it on and off. And then ideally, when you step on the accelerator for the immune system, you have more of these immune cells coming up in there, killing off cancer cells, and then ideally teaching themselves how to keep killing cancer cells. If we take a look at tumor samples of patients treated with this type of an approach, this is a paper by Nino Kioka out of Boston. What we can see on the left upper area, the left side, are all tumor tissues that have been dyed with the same dye that we see on the right side. So we can see there's a world of difference between these two. So one of them looks almost black and white. The other one here shows a bunch of markers for a variety of different immune cells. And the top row is sort of the expanded version, and then the bottom row is the more narrowed down version that fits kind of within that box that we have here. And what we can see is before initiation of this type of an approach, this gene therapy approach, the tumor is very immunologically cold, not a lot of immune cells here at all. But then when you turn on that accelerator, you have this huge influx of immune cells. So it seems to be doing what we want it to do. So that's the sort of brief summary of both oncolytic and viral vector gene therapy studies in glioblastoma. A few points that I want to highlight are that this type of an approach does hold a lot of promise in glioblastoma, and the wide range of ongoing studies and recent studies sort of are a nice attestation to that. The use of this approach, directly killing tumor cells, immune stimulation, as well as a delivery mechanism for gene therapy is exciting. All the trials that have been published thus far are early phase. And so we always want to take everything with a grain of salt when it's a relatively limited number of patients who have been treated. And so we want to keep in mind some of those points that I had highlighted earlier. Thus far, it does appear that this is a really safe approach, and that's exciting because early on there had been concern that this may not be as safe, as we would like it, that it could cause a lot of swelling in the brain, it could cause a lot of damage to healthy, normal brain tissue. And so far that has not been the case, but we still have to proceed with caution. And an example of that was the poliovirus study, where it wasn't the even starting dose that looked optimal, it was the dose level below that. And it's likely that what is going to be necessary for this approach to be successful is some sort of combinatorial approach. And so I alluded to using it in conjunction with traditional cytotoxic chemos, maybe making that cytotoxic chemo more effective. Also had numerous allusions to combining it with immunotherapies. And then there can be approaches, even beyond that. We gave an example of using it with radiation with tumor treating fields. The disclaimer here for you guys to read all the details. And I'm really looking forward to answering questions both about viral therapies as well as about immunotherapy more broadly speaking. Thank you.